Fantastic. So starting off here with our first speaker for today is Dr. Judith Flores. She is a fellow of the American Academy of Pediatrics. She has earned her medical degree from Mount Sinai Aishan School of Medicine and was trained in pediatrics and community medicine at the residency program in social medicine of the Montefiore Albert Einstein School of Medicine. She is board certified in pediatrics and in healthcare quality and management. She is a fellow of the New York Academy of Medicine and the American Public Health Association. Thank you so much, Dr. Flores, for joining us today and putting together a great presentation for everyone.
You're so welcome. And it's a pleasure to be here with you and with Gustavo Morales and everyone else. So I'm going to start, and I'm going to start by saying, first of all, I have no disclosures to make today, no financial or lineage disclosures, but I want to start with the basics. A lot of the information I'm going to give you today, it has been and will be changing, but the basics are the basics. So it's important to know these things and know how they affect all of us. Fundamentally, monkeypox is a virus, very similar to smallpox, much, much more rare, and really until recently not seen outside of the greater continent of Africa and some countries in Asia. So it's not chickenpox. It's much more serious than chickenpox, but it's definitely not as serious as smallpox. In about 1958, and I'll give you a little history. I'm not going to spend too much time on this because people get into a lot of this and I think it causes confusion. But in 1958, there was some research done on a couple of outbreaks of this pox in the 50s. And the name of monkeypox came because a lot of the research was done primarily on monkeys. But the origin to today is really not specifically known. In general, it's understood that this is a virus that comes from animals to humans, that is probably mostly propagated by small rodents, be they rats, be they we had one outbreak in the 70s in the United States. It was very small, and it was because people were bringing in rats, and these rats infected prairie dogs, and the prairie dogs infected some people. So it was very limited at that point. So we're really thinking it's basically related to the African rodent, and that is how it spread to us. So until 2022, all human monkeypox cases outside of Africa were really linked to international travel or imported animals. Next slide. When we look at the world, I think we have to have some perspective, and this is the same, pretty much the same for most animal to human transmission. That it starts in one country, and because we either bring in animals from that country or we travel from that country unvaccinated, and of course, unknown that we are infected, we spread it to the rest of the world. So if you look at this map, in May of 2022 is when we had the larger cases outside of Africa. We have had, up until then, about 100,000 cases in the world. But of that 100,000 cases, when you look at the number of deaths and the number of serious cases, at this point, it was really in Africa, mostly in the Democratic Republic of Congo. And there you will see for this year, they had over 12,000 cases and they had over 60 deaths. We are in a position now where we're declining in number of monkeypox, and we'll talk a little bit about that, mostly in the United States. But the way it spread and the way we think it spread was really people that visited these areas where there was monkeypox, were in contact with people that were contagious, brought it into countries in Europe, particularly the United Kingdom, Spain, and Portugal. And there were apparently certain celebrations at that time where there was a lot of physical and close contact. And that's where it started to spread to us in the United States. And as you see, it spread in Canada, United States. Many of you are from the islands. You know it's in the islands, it's in Mexico and in South America. Next. So if you look at what's happening now, to date, we've had confirmed a total number of about 28,000 cases. The number of cases we saw today, when I looked at the report for today, were really way below the 100 number. for the entire country. So there's been a lot of change. There's been a lot of decrease in the number of cases. There have been a lot of things that we've been able to do that really address this situation. I don't want to call it an epidemic. It's certainly not a pandemic, but this outbreak. And as you see, originally, most of the numbers were concentrated in California, New York, Florida, Texas, Georgia, Illinois, and I just put Puerto Rico's numbers there because of those are the last ones I found, but I think the numbers are even a little higher. But they're concentrated in people where there's a lot of people, a lot of international travel, and a lot of close contact. Next slide. So what concerns do you have about monkeypox? What concerns are you hearing from others? I'd like to see that in the chat box so we can start looking at that and I can focus some of my talk on that. Let's see if you have any concerns right now that I can address. I think it's supposed to go in the Q&A. Yes. So far, I don't see anything. Should we wait or should I go on with my presentation?
One question that did come in, Dr. Flores, which you might have some time to go over.
Sure.
To think of is non-sexual transmission.
Yes. Thank you so much for that. We're going to spend some time on that. Any other questions, or I'll just go on.
There's also in the chat box a question about, I'm sorry, in the Q&A panel, is it an STI or not?
It is not. It is not a sexually transmitted disease. Sexual transmitted diseases, by definition, are only transmitted sexually or heavily with sexual contact. And I'll talk about that a little bit more. It is a disease that is transmitted via close contact. And I'll show you a little bit more as to why I answered it that way. Next, I think we can move on then.
Okay, there's a couple of other concerns.
Then I'll stop. Okay.
Yes. There's a concern related to stigma about gay community.
We'll talk about that.
Okay, great. Why is it transmission from mother to baby?
I will talk about that.
Why is it more in men than in women? I think that's what that one says.
I'll talk about that. Okay.
That's all.
All right. So I think your questions are great because your questions are going to help me leading into my presentation. So it sounds like I may have be able to answer most of those questions. So I think we should move on then. So let's talk about transmission. So how is this? Why did I say it was not sexually transmitted? Because if it's sexually transmitted, it would be limited mostly to sexual transmission. And in the case of monkeypox, it is principally transmitted via close contact. If you have sex, it's close contact. If you are intimate with someone, if you are a caregiver of someone, that's close contact. Well, those of us that have cared for children or elderly adults know that that is close contact. Can it be spread by touching? Yes, it can be spread by touching if you have close contact to an open sore or body fluids. Can it be spread by touching someone's clothing? Usually not, but bedding, because we may have some body fluids on the bedding, fresh bedding can give you an infection with monkeypox. The thing about droplets, which we talked about a lot with COVID, is if you are very close to someone and they are highly infectious and you're not masked and they are actively sick, yes, you can get infected. But to date, it has not been said that monkeypox is airborne. That's important to know because COVID was airborne and is airborne. And it's highly, highly infectious as compared to monkeypox. It's even more serious, more widespread than monkeypox in that sense. Next slide. So how do we know when a person is infectious? So the good answer, the short answer to that is we may not know. We may not know because they may have rashes in parts of their body that they haven't identified yet. They may be in an incubation period. That means a period where they are infectious, but they don't have any symptoms. And this can go on for 1 to 2 weeks. And they can be infectious for usually it's 14 days, but they can be infectious for up to 21 days. So you can have a long period where you don't see symptoms and you don't know the person is infected. The second stage usually that people move into is a flu-like symptom stage. So we all know that, especially now in this time of year, depending on where you are in the country or out of the country, flu-like symptoms are always around. Flu-like symptoms are around when we get allergies, when we get colds, when we get the flu, when we get COVID, when we have a simple cold. So will it mean something? Will it not mean something? Perhaps. So these are stages where the person may feel a bit sick and is potentially, again, contagious. The rash stage is the more serious one, and it's the one where the person is most contagious, and it's the third stage. I'm going to show you some lovely pictures of rashes, just so you have some idea of how hard it is to tell whether this is a monkeypox rash or a rash related to another infection. But according to the CDC, a person is definitely contagious at the stage of rash. Next. I'm going to go over this slide just to let you know, if you look at this slide and spend 2 seconds just looking at it, fever, headache, muscle aches, backache, chills, rash, other than a rash that might be more particular to monkeypox or look like monkeypox, all these things can be related to anything. So my take home here is, when you feel sick, stay home and try not to have close contact with others. That's always a good idea, whether it's for yourself, for your children. It's always a good thing to do. And lately, I think more people are taking to staying home when they're sick, and I think it's a good thing. Next, please. So monkeypox signs and symptoms. I think I went through this already, but it bears me repeating it. It can start within 3 weeks of exposure to the virus. The illness typically lasts, the illness itself, from the time you start the rash to the end, is about 2 weeks. It can be more than that. Think about that. That means that the clients you work with, the patients you work with, the families you work with, and yourself, that means a period of incubation and isolation that's even longer than for COVID, until the rashes heal over. That puts people out of work. That stigmatizes someone as to why are they not going to work. So all these things have a great impact. Rashes on places that are intimate, rashes on your genitals, on your penis and testicular, your vagina, your anus, those are hard to find. And usually people, unless the rash is already spread to their hands and their feet or their mouth, can't detect that they're sick by looking at a rash, because it might be internal. So that really puts the person at even a greater disadvantage, because they don't know that they've been infected or are infectious for a longer period of time until it starts to show itself on different areas of the body. So that's important to know. The illness typically lasts, as I said, 2 to 4 weeks after the exposure to the virus. And if someone has flu-like symptoms, they will typically develop a rash about 4 days after the flu. The virus can spread from the time the symptoms start until the rash has healed. That means completely. Doesn't mean a scab, doesn't mean a little bit of rash showing, doesn't mean a little bump. It means completely new skin growing over, even after all scabs have fallen off and a fresh layer of skin has formed. So it really has to be completely. So even if your sores have healed, it's important to please make sure that you have good distancing from others and that you're not in close contact for a period of time. Next. It's a difficult time for people, because you're putting people in a position where they can't go to work, can't go to school, can't be around others, and you're basically going to out them as having monkeypox, and that may be very serious and dangerous, especially in societies where it's been linked so strongly to just people that have that are LGBTQ or men who have sex with men, even though they are the predominant group. But if we just link it that way in a society where they are penalized for being such, and there are many countries and many states where it's difficult to be an LGBTQ person. So you imagine if on top of that, the person is isolated and has to stay home, it really complicates their life. So the following slides show some realistic examples of the rash, and some people were a little concerned that these would be a little too much for you to see. I don't think so. I think it's best to understand that the rash can take many forms. And remember that even though it's a small number, children can be infected. And in the United States, it's extremely rare that a child be infected But in the rest of the world, the way we identified monkeypox, for example, in Africa, was that children were infected. The children were infected first, way before everybody else. And why would that be? Well, that's because the children had never received a vaccination against smallpox. The older person, the adult, and mostly in developing countries, had received smallpox vaccinations, and that gave them partial to good protection against monkeypox. The children really didn't have any of this immunity, were more vulnerable, were exposed to their parents and their society in close contact with their children or as a consequence of a pregnancy, and that's where we saw more cases in children. But I want to alert that right away because I know that we're going to have a concern about talking about children, and as a pediatrician, I know that monkeypox is extremely, extremely rare, and I'll give you numbers later. But let's look at the pictures right now and why I want you to look at them. Next, please. So this is the simple picture. You see it's on someone's hands, and you see actually in one of them, you see little redness around those two little white dots. None of these things really look alike. All of them look pretty different. And many of them could look like anything, especially the one in the hand above the third finger. You see that it's almost like a little blister. So why would somebody think they have monkeypox? Or why would you be afraid that person has monkeypox and stigmatize them? Next, please. So next, please. So this is a commonly used slide. You see it's the lesions are flatter. They're all over the hand. Next. This is a pustule. It almost looks like chickenpox. I mean, chickenpox starts, it is little pustules like this, and smallpox is like this too. The pictures I've seen of smallpox, I can't say I've ever seen smallpox, thank goodness. But you see, and that's it in a child's hand. As you can see, this could look like probably anything. Next. Yeah, this is beginning to heal. It's scabbing over, but at this stage, if you look at this, you'd say, oh, well, they're getting better. Yeah, they're getting better, but they're still contagious because skin has not grown over all those lesions, all those little areas where you see it almost looks like someone scratched it. All those areas are still open. They still are secreting virus, and this person is still contagious. Next. Okay, this is just to show you when it starts to heal over. It's beginning to scab over. There's some new skin. It's almost ready, but not quite. So this is almost at the end. Next. So who is at risk, at high risk? So the take-home message from all those lovely slides is you really can't tell. And if someone has a rash, it's a common thing that we do in hospitals and clinics. Someone has a rash, we bring them into a room, we isolate them, we figure out what's going on, we try not to expose them to other people because it could be measles, it could be chickenpox, it could be and measles, by the way, is much, much, much more contagious than monkeypox and much, much more dangerous for children in many cases. It's more common, was more common. We see it in places where people don't vaccinate, but it's a practice we do in clinics and hospitals. It's probably a practice you should keep. If you have a rash, it's unidentified, especially if a rash has fever, you should seek medical attention. Have somebody look at it, have your doctor or your medical team look at it. It's very important. Who is at high risk for contracting monkeypox? So I have some lovely pictures here, but the most important thing is when we're looking at the newest data, yes, anyone who is in close physical contact with an infected person can get monkeypox. It's important to remember, but who is really getting monkeypox? Generally, men who have sex with men have been a separate identified group. Persons with a weakened immune system are exposed. And I will add there, more importantly, persons with HIV that do not have antiviral control, that are not in good control. That is the biggest group of risk. And that's actually the group, if you are going to have an abundance of vaccine, if you have a place, and we should in this country, where you want to make sure people get vaccinated, rather than identifying people that and stigmatizing them, it's important to offer people the therapies that help them protect themselves. And for persons who are living with HIV, getting antivirals and getting the monkeypox vaccine is recommended. So it's to give them that general protection. Are elderly persons affected? Some are, and there has been some talk about giving vaccine for people that are in nursing home. Why? Because they're in close contact with their caregivers, and their caregivers can be anyone. And even though we use gloves and we're careful with them, they may be cared at home, they may be cared in a hospital, and they have a weakened immune system, definitely. How about children? Because I heard someone talk about children. Well, children under the age of 8 may not have the protection against monkeypox. I already mentioned that in parts of the world, children have never had any protection against smallpox because it's an eradicated disease. It doesn't exist anymore. So we're not going to give people a vaccine that's dangerous and painful when that disease doesn't exist. However, monkeypox in areas where it's endemic, as I said, areas where the animals are around you, or the animals that spread this virus are around you to give it to humans, or the humans give it to other humans, it's advisable to make sure and understand that children can be at risk because their immunity is a lot lower. We haven't seen many cases in the United States. We haven't seen mortality. What we have seen is a few associated mortality in women that are pregnant and in their babies. So let's go on to the next one.
Dr. Flores.
Yes.
If I may, about
yes.
the vaccine. Are you going to share a little bit more about the vaccine later? What is known?
The whole thing.
Okay, great.
That's why, I'll tell you, when I go through this, we're going to go back and have questions, but I hope I have touched on everything that we need to talk about, just to open it. Yes, I am. Next.
Thank you.
You're welcome. So monkeypox virus transmission in pregnancy. Somebody already asked this question. So I had the lovely picture of someone pregnant and expecting their baby. And what a uncomfortable position to be in, to now, on top of worrying about COVID, which you should vaccinate if you're pregnant, definitely, and the flu and RSV and everything else that comes at us when you're pregnant and you're so vulnerable and so worried, now you have to worry about monkeypox. Well, I think unless you have close contact with someone that you suspect has monkeypox or is an at-risk group, reducing your contact with people is advisable in that sense. But it's important to know that there have been some fatalities in this country. I think there are about 10 or 12 reported deaths in this country in people with as an outcome of monkeypox. They don't know if it's directly related, but there have been very, very rare and very few in number. But of those, I already mentioned people that were HIV and not under antiviral treatment, highest risk. One of the second ones is people with cancer, like solid tumors, which are the big tumors that require a lot of chemotherapy. And the third one is women that are pregnant. So in pregnancy, being infected with monkeypox does affect the fetus. It can cause stillborn, prematurity, and death in the newborn. So it is a very serious thing for a fetus, an unborn child, to be infected with monkeypox. So the cases are rare. The virus can be transmitted across the placenta, so the baby can be infected. It's important for pregnant patients to reduce their risk. And if any pregnant woman suspects she has monkeypox or has been exposed, she absolutely needs to be seen. Physical distancing, washing hands, covering sores, all those things that we talked about before. But actually, in most of the identified cases of monkeypox in women that are pregnant, they are hospitalized. Next. How can a person lower their risk during sex? So that's a tough one. But I will say, when you look at the numbers now, I feel very encouraged because of the fact that people that are at risk, persons that are at risk, along with the advocacy of groups that represent them, have been able to reduce the number of cases, their exposure, and have been able to vaccinate at good numbers in the US. Not specifically in every area, because we know that there are disparities, but in general, we've seen that cases come down significantly. As I said, I think there were 20 or 30 cases reported yesterday. It really is much, much lower. And a lot of this has to do with the fact that people took this advice to heart. What can a person do? Avoid close contact, including sex. So being intimate with someone that you know, that's your regular partner, is one thing. being intimate with multiple partners or people you don't know, maybe at this point unvaccinated, and maybe with HIV that's not in good control, is not advisable. If you don't have a provider, you really need to find someone in your community, be it an organization like OASIS, or I'd say in New York, it's New York City Health and Hospitals, and a lot of hospitals now are very attuned, and community, federal community health centers are attuned to getting people in, getting them vaccinated, and getting them care if it's necessary. So having somebody you can talk to that has some medical background is extremely, extremely important at this time. And it has worked. We see the numbers coming down, more people being more careful during the periods that they may be exposed or infected. And also a lot of contact tracing, people coming forward and saying, you know, I had sex with this person and they may have been exposed. It has worked. And the vaccine. So getting people engaged and advocacy has worked and will work. Next. What to do if you think you have monkeypox? The first thing to do is to go get yourself seen immediately. You don't know, you can't tell. Yes, there's testing, but the testing really takes a while. And in a lot of facilities and a lot of places, there is no testing that's quick. So really people are, depending on the severity or their condition, they are either asked to isolate for the period of time, given some support for pain. By the way, monkeypox, especially in the genital area, is extremely painful. Tylenol, acetaminophen is not going to work. So we're using a lot of other medications that are prescription only and that have been working. So just taking those things, you know, the individual will be miserable. So these are general recommendations to keep the rash clean and dry. Don't expose it to the sun. Don't expose it at all. You have to pretty much maintain some quarantine. You need to inform, and you need informed consent, however, if you're going to get treatment. So I'm showing a picture here of Mpox, which is a short name for this medication. This is an experimental investigational drug. That means we think we see that it's working. We're starting off, we're using it as almost an emergency use, and people have to sign consents when they take this drug. And this drug is only given to people that have severe cases, because you can have very bad outcomes from severe cases. You can have infections that spread beyond the usual month or so. You can have consequences with people that are severely infected with infections in your eye, infections of the lung, infections of the brain, or fatalities or deaths. We see it in other countries. We've seen, I already told you the number of deaths in other countries that have basically not had any access to this treatment. So it's important to know it's reserved for people that are severely affected. It has to be given under the supervision, of course, of a physician, and you have to have informed consent. That means the person has to be able to understand what they're taking and sign. So another barrier might be language, making sure that this is available to people in a language that they prefer. So it does suppress your immunity, and it is given for people that are not in good HIV control. It's very important. Next. Protect yourself and others from monkeypox. Number one, we already talked about close contacts, making sure you're not with someone if you have flu-like symptoms or you have any rashes, and get it seen. The other one is get vaccinated. Even if you're exposed, within a couple of days of exposure, if you're vaccinated, you do have protection. And I already went through the avoidance of sex or intimate contact with partners if you have a rash. And the basic stuff that we did for COVID, or we do for anything, washing our hands, making sure that we don't share bedding, isolating ourselves, and talking to your healthcare provider. Next. So let's talk about the vaccine. So who's eligible for the vaccine? The following people in New York, I'm pulling data from New York City because that's where I work. But in general, this is what the CDC also recommends. So people of any sexual orientation or gender who identify who have or may have had multiple anonymous sex partners or participate in group sex. That's pretty clear. People of any sexual orientation or gender identifying whose sex partners are eligible per criteria. So if you've had sex with someone who is at risk or eligible in the first category, you should, as a contact, be vaccinated. If they know or suspect they have been exposed to monkeypox within the last 14 days, they can still get vaccinated. And anyone else who considers themselves to be at risk for monkeypox through sex or intimate contact. So in New York, we're letting people decide, and we're saying people of any sexual orientation or gender. And this has helped us a lot in New York recently, especially with Stigma, because the worst thing was in the beginning, people going online or going online virtually or online physically, and basically outing themselves in front of their community if they didn't have a source of healthcare. So always having that contact, that person, that trusted person, a trusted place is extremely important. But these are the eligibility criteria for the vaccine, MPX vaccine. Next. Okay, what equity, I did want to know what equity challenges are experienced related to MPX. And we'll talk, I know that Mr. Morales is going to talk a lot more about that, and I'm interested in hearing what he has to say myself. But I do want to see if you can write in the chat what you've experienced in terms of stigma and marginalization of people that may be affected. Okay, let's see. I don't think it's a chat. I think it's the Q&A. We'll go back to Q&A. Nope, nothing there. Brenda or Sarah?
Yeah, so at this point, if everyone can go ahead and share any challenges that they're experiencing related to equity and monkeypox at the moment, feel free to just drop that in the chat box. And just because it isn't technically a question, but we'll go ahead and Dr. Flores, if you want to continue, we can always come back to these.
Yeah, this will come back. Yes, thank you very much. Next, please. What is Genosis vaccine? So this is the vaccine that is now licensed by the FDA. So unlike the treatment, the vaccine is licensed. It is effective against monkeypox. It is not the vaccine that's used for smallpox, because that vaccine has many, many side effects and isn't specific for monkeypox, and is more dangerous than needs to be when we have this vaccine. So this vaccine is a 2-dose, and now it's given subcutaneously. That means right under the skin. It's a 2-dose. It's given to anyone over 18 years of age. However, there are situations in which we have to give it to people under 18 years of age, and that is a situation that has to be cleared with the medical provider in the situation and also the jurisdiction in which they work. So in many cases, I take care of adolescents. So in some cases, if I have an adolescent and I feel that they could benefit from the vaccine, I will work to try to see if they can have the vaccine. So it can be given to anyone who's had an exposure 4 days or less. If you're beyond 4 days, it's really not going to protect you that much, but we can try. It reduces the severity of symptoms. And I already said that for some people, the severity of symptoms is great. For it, even though it's rare and rarely fatal, the pain associated with monkeypox can be severe, and the symptoms and the consequences can be great. So it's important to know the vaccine is very useful. A person is fully vaccinated 2 weeks after the second dose. Remember, the 2 doses. It doesn't produce much scarring anymore, because in the beginning we were giving it deeper, and it could cause keloids and scarring and all sorts of problems. But it does have some side effects. People, as the usual, they get tired, they have headaches, they have redness in the area, and some swelling. And as I said, we're not using the intradermal, we're using the sub-Q, which is just under the skin, and has a lot less consequences. It's an effective vaccine. It has to be given before or immediately after exposure. And it should be, the recommendation now is that is wider, as you see, for the vaccine, and people that are, especially people that are living with AIDS and are not in good control and not getting antivirals, should be receiving this vaccine. Next, please. So the number of vaccines first dose administered. So now we're going to talk a little bit about disparities. our favorite. And I'm going to show you a little bit about what's happening particularly in Latino men. And this is, I believe this data excludes Puerto Rico and some of the other countries. It's really US stateside. But if you look at the numbers can tell you the story. And the story is that you get the first bar as who is getting vaccinated, who is not getting vaccinated. Who's not getting vaccinated? People of color, men of color, particularly Black and Latinos. And why is this? And particularly for Latinos, what is the issue? Some of the issue is just equity of access. They haven't had access to healthcare anyway. They haven't had access in their language in a preferred way. And they haven't had access to treatment if they're HIV, to antivirals. Information. I have a pet peeve, and my pet peeve is I find information everywhere. I can go online, I can find things. They are wonderful. They are at the right reading level. They are not in anything but English. And I look around and then I'll find Spanish, or I'll talk to the departments of health, people I work with, and they've done a very good job, but it's always a lag. There's always a lag. So being linguistically and culturally appropriate is always something we need to deal with. Technology, they may not have the technology. They didn't have the technology to make appointments. Why we're making appointments online, I understand why we did it initially, but now we're not. Now it's pretty much, at least in New York, I don't know about other places, that's why I want to know what you have to say. We've gotten a lot better with letting people come in and going to a place where they can get their general health care, all their care needs addressed, make it their medical home, and then be able to get these vaccines or care for anything that they need. They don't have much access to treatment. If you're going to treat somebody, I did mention you have to have informed consent. Informed consent, what does that mean? That means you have to have someone that this has to be presented in the appropriate language and has to be discussed with the patient in their language. It's just not a translation, it's a discussion. So, and the fear of stigma. Because especially in the beginning, and I don't know about other states, but in New York, and I know from people in Chicago and California, people were essentially having to out themselves in their communities to get the vaccine. Next, please. So we're coming back to the question of stigma. And I know we're going to have some discussion on that. And as I said, I'm very interested in hearing what Gustavo has to say and his approaches so I can also learn more. But the thing about stigma is it's very interesting how stigma can really limit you from getting the care, limit you from seeking care. And that's been seen in many occasions and many reasons. Even for COVID, we had stigma where people were not able to get their care. But particularly for monkeypox, since it's been identified with being LGBTQ and also with men who have sex with men, they are stigmatized. One of the things I heard and I will stop with this, is that really made me take pause is I was listening to something from the World Health Organization, a presentation this week in preparation for this discussion. And it didn't strike me that stigma here in the United States, yes, can be difficult, but in other areas, if, for example, if the World Health Organization designates this as an epidemic, which they haven't, it's an illness of concern. People that seek care or seek treatment or seek vaccines for this, since it's highly identified with men who have sex with men in many countries, are really taking their lives in their hands. Because there are laws on the books that if you are not a heterosexual person, if you are LGBTQ of any ilk, you are either jailed or you are going to have severe consequences. So I learned that this week, and I sort of knew it, but I didn't understand the great impact that this can have. So I want to end here, and I want to hopefully, I will answer any other questions as best I can. And I want to listen to what Gustavo has to say. And thank you for this time. And let's go on. Let's learn more. Thank you all. Oh, these are some references and links in case you want to learn a little bit more or you want to use some of the references I have used. Muchísimas gracias.
Thank you so much, Dr. Flores. We do have a few minutes if anyone has questions that they'd like to insert into the Q&A panel. I know that one question that came up, or someone was actually sharing in terms of the stigma, I believe that they may have experienced. Please correct me if I'm wrong. They mentioned that people started to ask them and share notice about monkeypox. And so let's see if there's another question here. I believe we did have another question. Sorry, here, I'm just gonna scroll up very quickly. It looks like others were actually mentioning lack of access in different boroughs. I believe this came up when we were speaking about the vaccine, but this may have also been related to resources in general.
Well, it's gotten much better here in New York, I will say. But in the beginning, it's like those of us that work, my colleagues in Department of Health, were really it was like deja vu. Why is this happening again? Well, because it's always going to happen. Whatever outbreak we have, whatever situation we have, it's going to happen because the fundamental question is getting people adequate healthcare and quality healthcare where they live, equity in healthcare, general. Yes. So, yeah.
And in terms of patients who one of our participants shared that they've had some patients who have experienced discrimination and were mistreated at an emergency hospital when they found out that they were there for monkeypox treatment.
Oh, yeah.
So, healthcare professionals and clinicians even actually sharing that discrimination is also very tough.
Oh, it's very tough, and you'll see that because it's waning now. The numbers are coming down, but when the numbers were high, people were worried because healthcare professionals can get infected. If you're going to touch a patient that has monkeypox, that's close contact. That's why we wear gloves and a mask, and that's why we know how to protect ourselves. By now, we should know. So it's not a justification at all, but fear pushes that button of bias in people, be they healthcare professionals or be they anything else. So.
And one of the other things that came up was that the best prevention strategies for non-sexual transmission, which you touched on. But one of the things that I actually wanted to ask in terms of the vaccine efficacy, like what's known or unknown, do you have any additional concerns at this time about the vaccine or anything that you're hoping that is shared about the vaccine?
I think that the vaccine, since it has full FDA approval, and from the numbers we've seen, and also from the drop, I mean, we've seen monkeypox at this level in May, and now monkeypox is at this level in the US. And a lot of it is related to vaccine. The vaccine is very effective, as I said, has very few side effects. It is quite effective. And the other thing is natural immunity. Let's talk about someone who got monkeypox and recovered and didn't need vaccine because they didn't get a chance to get it. The natural immunity, unlike the immunity of other things like COVID, can last for a while, can last maybe for a year or so. So natural immunity is good, and the vaccine does give you very good protection and is safe.
Perfect. Okay, so I don't see any other questions at the moment, but there may be others that come up. And again, feel free to drop your questions for Dr. Flores in the Q&A panel. And then we'll go ahead and move forward with Gustavo's presentation.
Oh, yes.
But then we'll come back to more questions.
Yes, I want to hear Gustavo. Thank you all.
Thank you so much. Gustavo, feel free to bring up your slides and then I'll go ahead and, I apologize, 1 second.
Well, can you all hear me?
Yes, Gustavo, I apologize. I can actually, I'll introduce you and then we'll move forward. 1 second here. Perfect. And so our second speaker for today is Gustavo Morales. Gustavo is a skillful sexual health counselor and facilitator, currently serving the community of New York City as the Director of Access to Care and Services Department of the Latino Commission on AIDS. He was co-chair of the High Impact Prevention and Engagement Work Group of the New York City HIV Planning Group. And Gustavo is actually one of the national trainers for the National Council for Mental Health Wellbeing and has certified over 300 Latinx New Yorkers on mental health first aid, which I know firsthand is an amazing training. Thank you so much, Gustavo.
Thank you. Thank you, Rosie. Thank you, everyone. And thank you, Dr. Flores, for this thorough presentation. And I want to especially, I do want to commend the work that Dr. Flores did, especially centering and bringing forth the community, the marginalized communities, the people that are currently and regularly being outed and marginalized in the systems, because no matter where we are, no matter what our study background is, we should always bring them into the spaces. So I really, really commend you, Dr. Flores, for bringing us in while talking about the clinical end of monkeypox. So we're going to be talking about the response that OASIS had. It is a New York City-based agency, so I want to preface with that, which means that maybe what happened here might look different from where you are or might have different options, but also it's important to highlight it as New York City, especially, was one of the epicenters of this outbreak. We are a community pride center. We rely a lot on the community being here and being part of what we do, and we love centering them. So we always say that they are part of the soul and the heart of OASIS. We are a space that is designed for the Latinx community and our allies. So you don't have to be Latinx to come into our space. You better know some salsa or some merengue, or if not, you can learn. But definitely, if you love someone who's Latinx, if you support someone who's Latinx, regardless of your background, you're more than welcome to join us in our space, and you will be received with open doors. We are a space that is designed to be available for the community to drop in, to enjoy, to meet other people in a safe and modern place. The idea is making sure that we bring to the community a space that's safe for them, and it's not centered on the services. You can get the services that we offer in 1,000 different other places in New York City. We want you to get them in a different way, and we want you to come in because you feel safe. And I highlight this, and I know talking about safe spaces is something that we all do, but the reality is that with COVID, when it started, it broke the whole model. For years, we have been promoting come in as a community, mingle, get together here to be safe. And all of a sudden, the whole speech changed, and it was being together is not safe. Stay 6 feet apart. Go over there. That broke our whole model. And when we were feeling that COVID was kind of being managed and we were able to open up the spaces, monkeypox came in again, and many questions again. Is it safe for us to do like we used to do and huddle 5, 10 of us in the same sofa watching movies? What should we do? So all these different outbreaks and the COVID pandemic really took a toll, not only on our space, but on our community as well, because it just put us all in a place of fear and in a place of we had no idea how to be us again and how to enjoy the space. We're working back on it, we're getting better, but definitely I do want to highlight that, because for marginalized communities, for communities of minority languages, sexual minorities, etc., these safe spaces are the difference between potentially where I am safe and where I am secure, and back home where I am discriminated or where I am hidden. So we have to make sure that when we manage public health messages and personal health messages, we feel that gap, because a lot of the public health messaging, and Dr. Flores mentioned it about, at the beginning was very stigmatizing, and it was about gay men, and yes, this community was being most impacted by it, but it didn't mean that they were the only ones getting it, and not having that nuance in the headlines and when we talk really hurt. And I'm also thankful for Dr. Flores for mentioning it very clearly, anyone can get monkeypox. The only thing that means that more men that have sex with men are getting monkeypox, the only thing that means is that they need more help, nothing else. So we want to make sure that we highlight that. And we love working with people from all walks of life who share the common goal of improving our sex life, our mind, our body, and soul. And here is where I'm going to start moving with monkeypox, because like Dr. Flores mentioned, monkeypox is not an STI, it's not a sexually transmitted disease, it's not a disease that would traditionally be in the radar of OASIS when we focus on sexual health, when we focus on HIV, when we focus on other more traditional, quote unquote, diseases that are affecting sexual minority communities. But with COVID, we definitely learned our lesson. And we said, we have to look more than just this, and we have to apply what we have learned from HIV and how to reach out to people to talk about HIV and apply it to COVID. And when monkeypox came in, and there were still rumbles, it felt like this thunders in the background before the storm comes. We were already talking about monkeypox. We were getting as little as information as was there out in English, translating it and putting it in our social media. We didn't have any strategy at that moment. I'm talking early June, mid-June, right before Pride. We're busy, but from the get-go, we were like, you know what? We have to put things out there. Was sporadic, it wasn't a solid strategy, but things were being said. And I highlight that and I start there because it is important, if you especially are working in a community-based organization, don't get stuck in the same things that we always do. We are the canaries in the mine. We start hearing things way before the data shows it. And when even we didn't have any mandate, when no one was telling us talk about this, we were already like, you know what? It would be great if we reshare this. It would be great if we take this and translate it in Spanish and put it. So even before anything structured happened, we were already trying to fill this information gap that we were seeing potentially. And this speaks a lot about equity, and this speaks a lot about access. So although we are focused on sexual health, and monkeypox is not a sexual health disease, we were putting our fingers there already. But moving a little bit forward, right? Since we believe a lot in being centered in the individual, in being holistic, in being responsive, we started doing all this work. And in the translation and putting it out there, it was not just to the MSM community or the LGBT communities. We host a group of families, of parents that love someone who's LGBTQ. We were posting information there as well. Hey, talk to your kids about this. Hey, so because we were making sure that happens. So we want to make sure that what we believe in, that's being as sexually as healthy as possible in a sexual sense and in a primary health sense, but also using all the networks that you have, all the support networks in the Latinx community, in the Black community, the family is so important. So making sure that those messages are not siloed, are not just in one community, because that can easily go into stigma if it's not addressed. So unfortunately, this is where New York City was close to June 14th, July 14th. The whole system broke down, literally. And I wanna stress that although the system broke down, the people within the system were battling intensely. Some people criticized the Department of Health and their response, very warranted critics, but the people inside were reaching out on our phones every hour, just trying to make something happen. But the reality is that many lessons that we learned from COVID were lost. 30 minutes after the appointment portal was open, it crashed. We didn't have enough system and bandwidth just to provide the few vaccines that we had. There was no need for that. And Eric Butcher and other council members from New York City started addressing that, and they started requesting accountability and making sure that something happened, because we have been working with COVID for the last 2 years. Why couldn't we apply the lessons that we had with COVID and apply it to this? Meaning, make sure that you reach out to the community, make sure that you put focus on community-based organizations who are the people that are going out, that have the ear of the community. Why are you not doing that? And you're focusing everything on a website through your sexual health clinics, which once again stigmatizes, which asks the question, is this an STI or not? If it's not an STI, why is it being treated and vaccines just in STI settings like the sexual health clinics? So a lot of the lessons were lost. And fortunately, a lot of people were asking the right questions. The Latino Commission on AIDS, OASIS, the Wellness Center that I'm speaking about and I represent, with other members decided to jump into it and advocate. And why we wanted to advocate. Right at the beginning, we were seeing a lot of reported cases among the white community, among the Caucasian community, and we knew that this meant it's not because we are not being impacted as Latino people, it's just that our numbers are not being tallied yet. We need advocacy, we need to jump in, and just like that, in a matter of weeks, the Latino men were being impacted mostly by monkeypox. They were the highest community of impacted by monkeypox. Yet when vaccination came out, we were only getting a minimal amount of access to the vaccine. African American people and Black people were faring even worse regarding the equity. And we have here some numbers. This data is from a few weeks ago when I did the presentation, but at a moment, Latino men were about 33.6% of all the communities impacted, the highest, the most impacted community, but only about 23% of the vaccines, were being given to us or accessed by us. So there was at least a 10% gap where just to try to get equity, and when we're talking about us being mostly impacted, it's meeting that need and going above, because we know that data lags, we know that reporting lags. So all of this happened, and the Latino Commission and other agencies decided to jump in together and automatically go into advocacy. You system do not have a response yet. You're trying to make something happen. Let me help you. Let's jump in, and let me make sure that you institution who is trying to set up the system, remember who you have to talk to. So I want to commend Colin Lord, I want to commend Bosses, I want to commend the 6 partnering agencies that comprise this first group. And we just went right into work, and we started asking the system, the government, not only the New York City government, but the state and the federal government, reevaluate how you are distributing vaccines. Don't focus just on this very limited process. Like the doctor was saying earlier, make sure that when you have this eligibility criteria, I don't have to out myself. I remember when I went to get the vaccine, I was in the middle of the street and I was literally answering, yes, I am gay. Yes, I have more than one partner. Yes, yes, yes. And I was in the middle of the streets. So there was no responsive or holistic or careful way of doing this. And we were advocating, hey, do it differently. Reformulate this. We were advocating for an improvement in the distribution mechanisms to accelerate the process. We partnered with other CBOs to create material for your stigma and discrimination. And we requested, hey, reach out to us. We can help you, government. We can help you, system, to do this. And we are here for that. We also wanted to make sure that the proportion of vaccines allocated to New York City was equitable and lined up with the amount of cases. We wanted the city to declare monkeypox or the monkeypox virus as a health emergency so that funding could start moving into the different places, and talking about requiring that the FDA shift TPOX, and the doctor mentioned about it, as an emergency use authorization, just to make it available for those who might need it, especially for the folks that were having very serious symptoms. And of course, this is something that we have been doing for the longest time since this outbreak started, focusing on trying to rename monkeypox, or as a minimum, refer it in other ways, just to make sure that the usual association with race and other things are not present when we're trying to address an outbreak that's definitely being impacting a lot of minority communities. So we wanted and we advocated to make sure that this happened, and that's what we refer to as MPX or MPV and everything that we do. So not only that, very quickly we jumped into action, and sometime mid-July, the New York City DOH stepped up and created this CBO referral program. Something is better than nothing, but it was a parallel program. So those who could get an appointment through the portal, and the doctor mentioned it, for that you had to have internet. For that you had to understand English. For that you have to have the space to do things privately. For that you have to have time from your work. That doesn't happen for many Latino community members. That doesn't happen for many Black community members. So the system was not designed in a way that we as a community could access easily. So the DOH created a parallel program called the CBO referral program, where if you have the opportunity to get the vaccine through the portal, great. If not, us community-based organizations were reaching out to the community. We were literally pen and paper, writing names, zip codes, addresses, times on pen and paper, passing it into an Excel sheet and sending it to the DOH every day by 5 p.m. We were allocated between 10 and 20 vaccination slots that had to be filled up by 5 p.m. for the next day, which talks about equity. How many in the Latino community, how many in the service community have the privilege of saying, I have space tomorrow, let me go? No, sometimes we needed 2-3 days headway. So although this program was in place, it didn't cover everything, and we had to advocate for that. And we also then started working with the New York City's Health and Hospital System, and we actually created an MPV clinic within OASIS. And I want to commend the New York City Health and Hospital System because they reached out to us and they said, we have the resources. You know how to use them. How can we make them work for you? It was not about, hey, I need access to the community. Can I jump in? No. They said, how can we make this work for you? What do you need from me for me to be able to put this clinic in your space? And that allowed us to have daily vaccination within OASIS. So we were not only referring out, we were actually bringing people into the space that they already know, where they're comfortable to get the vaccination. We were getting between 30 and 35 vaccination slots per day, but they were distributed on a weekly basis. So I could answer someone's phone and say, hey, I don't have the appointment. I can see you Friday, not tomorrow. They have time to plan. So we were able to engage community members who have been historically marginalized and did not have access to care through this model. I want to highlight a quick short interview from Associated Press about the clinic and how it looked.
Okay. Well, what's this?
With a little bit of food, right? It's tolerated.
Sorry, Gustavo, do you mind just restarting the video?
Se vacunen y tú sabes para andar.
Sorry, could you say that again?
Sorry to interrupt. Could you restart the video just because it's coming up a bit low?
Got it.
Thank
Okay.
you.
I have it on my highest setting, but okay. All right.
Okay. Well, what's this?
With a little bit of food, right? It's tolerated.
Bueno, mi consejo es que se vacunen y tú sabes para andar protegido uno mismo y proteger a los demás, ¿entiendes? Y eso, y también cuidar a los familiares, tú sabes, para que no estar enfermos.
That whole thing about the cold compress and stuff like that.
Señor, ¿usted viene con la mano derecha o con la mano izquierda? Ok, entonces se la van a poner en la izquierda.
Por eso que
the people who work in community-based organizations like us are the ones who have the real access to the community. The demand has been huge. We alone, being a good part, has secured at least 1,000 vaccines within the last month. On site, we have been seeing between 45 and 50 people per day on this site for the last week and a half. The messaging and the conversations is very varied. It goes all the way from fear to anger, to be honestly. The access to the vaccine, especially for Latino people, for Black people, has been very hard to get, very limited, unfortunately. Right now, Latino people are the most impacted community in New York City by monkeypox. Yet, we are not even close to what other communities are getting in regards to access to vaccine.
Es un poquito difícil, de hecho porque mis amigos buscaron la organización y pues gracias a ellos pues yo estoy aquí. Pero sí cuesta encontrar un lugar donde te pongan la vacuna. Me siento protegido la verdad. Es una protección que ya yo me siento ya más tranquilo que porto la vacuna.
So it became a slogan, access the vaccine in a safe space. Come here, get it, where you get your food, where you chill, where you meet your people, come here and get it as well. And that really was a game changer when trying to reach out the community. But I want to highlight when we got the first call from the New York City Health and Hospital System, and they said, what do you need? One of the first things I said, if you want to come into my space, you need to bring people that speak Spanish. You need to bring people that are diverse. I need to see racial diversity. I need to see people who are fluent in Spanish. And if you don't have, or not everyone speaks Spanish, which I understand might not be an option, bring access to linguistic interpretation. And automatically they tip their hat and I said, yes, let's do it. Let's make it happen. 2 days later we started the clinic, and for the whole process of the clinic, we had at least 2 or 3 people that spoke Spanish there, and whenever when the New York City Health and Hospital System might have an issue, they did reach out and they moved heaven just to make sure that we had Spanish-speaking people within our space. And I say this because it's also important, us as community-based organizations, to step up and ask, you need to bring this, because the access through my doors has a cost. I am bringing the people in. I know that it has a cost. Please make sure that you're supporting and responsive to our needs. So we also created a campaign that ran throughout all this time that focused on, hey, get the services in the language that you speak by the people that look like you, in a place that you already know, in a place that you already feel comfortable with. So continuously through social media, we were doing multiple promotion materials. This is another small video. Please be mindful of your headphones. It might be a little bit loud. So we just make sure that we put people's faces first. We let people know we are here to help you, and we're very thankful that the resources that were out there were put into our hands, the people that actually understand the communities and know how to work it. In my last few minutes, I want to highlight these numbers are from late August. We just have updated the numbers. I just didn't have to put it there. But in a matter of a month or so, we already had secured 1,032 appointments for the Latino community, for Black community members. And between August 14th and August 24th, we had actually in-person vaccinated 303 people within the clinic that we created at Oasis. So we were working at a neck break space, but we were aware that we had this to happen. And I know this is cliche, but I always say it. Sometimes we get stuck in the analysis paralysis. What should I do? Just do something. Just do something, and you can start making up for time later, but just make sure that you start. I also want to highlight some of the impact that we had on the equity. So 83% out of those numbers that I just presented, 83% of those people were Latino, Latinx. The other good part of them were either Black, or they were Asian, or they were other races, but 83% of the people that we reached out and connected to the vaccine identified as Latinx. About close to 10% of the vaccines distributed through our CBO referral program and in our clinic were for folks on 24 years old. And we know that younger communities can be hard. The city was reaching around 9%. So we were doing a little bit better than what the city was doing at this moment to reaching younger communities and getting them vaccinated. And also there were some lessons learned that I want to highlight. So be flexible. I know this is, we can get tired, but I got a call on August 10th. On August 12th, we already had the clinic. Yes, it required a lot of work, but we were flexible. We jumped into it. Make sure that if you are the people who have the resources, if you're a hospital system, if you are a government system, reach out to those who have a relationship with the community. Make sure that you bring them in, talk to them. And I know we have said this 1,000 times, but it really happens. But this is a good example of when that happens, and it happens quick, the success that you can have. And of course, bring those resources to the community spaces. We already have the doors open for the community. Come in and bring them into our space. We invested, and this is the right word to use, invested 496 hours at the moment of this report, mid-August, 496 staff hours on these efforts. And I'm not talking that this were close to 500 hours that we didn't do anything else. We were still doing HIV testing. We were still doing STI testing. So it was at least 500 hours of work on top of the hours that we were regularly doing on our daily basis and what we were funded for and what we were mandated for. And at a management level, we had a lot of conversations. How do we make this sustainable? How do we make sure that this is something that we can justify? And one of the first numbers I ran was, so out of this 500 hours that we invested, we saw at least a 69% increase in wraparound services. So you came to get a monkeypox vaccine or MPX vaccine at Oasis, but you also got an HIV test. And so we invested these hours that we were not funded for work that we were not funded, but it definitely impacted and helped us a lot in making sure that our other services were also administered. I want to highlight the work that people like Karina Escamilla, Valeria Paz, Pedro Hernandez, Nelson, and all the staff at Oasis did, because it was immense, but we had the commitment to do it. We unfortunately had 5 different clients that were not able to get the vaccine before they already were presenting symptoms. But I want to highlight this message from someone, and it says, muchas gracias. You helped someone living with HIV and other serious medical conditions get this much needed vax. That made a whole difference. And I can speak for all the other staff that were helping. The amount of text messages and emails, thank you, thank you, thank you. That alone meant so much for us. So I want to very quickly invite all of you. We are talking about equities and inequities. We are celebrating the week against transphobia. You can take a quick shot of this and you'll be able to join us and celebrate the week against transphobia, where we are saying no more transphobia. And like I mentioned, when we talk about HIV, when we talk about all these other diseases, when we talk about Black communities, Latino communities, too many times we focus just on the individual, but we always forget that what might expose me or what might make me more vulnerable to get monkeypox or HIV, which are a lot of them tied to behaviors, have a root in families. So we want to make sure that our families are also part of it. This is our support group for family members, Spanish-speaking family members who love someone who's LGBTQ. And please join us, spread the word. This is through Zoom, so we have folks coming in from Mexico, from Colombia. You don't have to be in the US to join and get the support as a family member that you might need. And with that said, I'm done, and there's space for some questions and answers.
Thank you so much, Gustavo. That was, everything is amazing that you all are doing and everything that you were able to do in such a short amount of time. So we'll open this up for questions. Please go ahead and put your questions now in the Q&A panel. You're more than welcome to share general comments, any words of encouragement. As Shay mentioned, we're also impressed, I'm sure, with everything that you were able to do and your team, right? Because everything, especially with community-based organizations, it's really a team effort. But again, such an amazing initiative, and everything that you were able to do in terms of advocacy, it's really shows. And I'll go ahead and have a few seconds here for any questions that might be coming in. Our participants have been saying, I should say, not just now, but amazing work, great presentations from both Dr. Flores and Gustavo. I think everyone who has joined us today can certainly agree that you were a dynamic duo here in this case, being able to give us the facts and also follow up with an amazing example here of being able to apply the information for the community and with the community in mind. If anybody would like to share any additional questions for Dr. Flores as well, now is the time to do so. Dr. Flores, I'm not sure if you have anything else that you'd like to share. Meanwhile, we wait for a few questions.
I'm just great. It's great to sit here with Gustavo and hear all that you did, because I did hear it from some of my colleagues at DOH. And I'm just hoping that you can extend and sustain with health and hospitals, because people deserve to have access to primary care. And with New York City Care and all the programs there, you're ready to open up your FQHC right there.
That's amazing.
Thank you.
You're welcome.
I'm not sure if you had anything else that you wanted to share, anything about where you are now. You shared a little bit of what you're doing now, but anything else that may come to mind? And in the meantime, I'm going to bring back up some slides, but feel free to continue.
I do want to real quick, I kind of glossed over it real quick. And we were talking about stigma, and there were questions. I think it's important to understand, I know it's hard, there's a difference between public health and individual health. And many times when we hear things out there in the news, they are public health conversations, not individual health conversations. So that gets conflated, and sometimes we ask questions as a community member that don't have answered. The doctor said it very early. In the first few days, for the very first few weeks, we don't know. But the question might be, do I have it now? Do I have it now? So us as community members, we have to I understand there's fear, I understand but we have to do better in making sure that we educate ourselves, and if not, ask the questions that will allow us to be educated and listen to the people that can educate us, because many times people reach out with fear, and we were able to address those fears by giving them answers, even though I could not categorically say yes or no, but we gave them more information and kind of deconstructed the public health messaging that was very specific around MSM to the individual level messaging that you might need as the person who's sitting right in front of me.
Exactly. Exactly. I mean, and one of them is, I know the issue of sexually transmitted, that is a very narrow definition. You can get so many things through sex that are not just sexually transmitted. And that really hurt a lot. And I think that our mindset is that we have to be broader, and the individual, this is the job of a healthcare provider, is to deal with the individual. That's why I'm hoping one day that places like Oasis, especially your place, can be broader in what they offer people, because people need a home, and I applaud the fact that you include familias, because that's a big mistake, especially with Latinos. We don't include families. We assume they are not involved, don't care, and that's not true. So getting the strength of the family when they are available, it's extremely, extremely important in all practices. So I applaud you.
Thank you both so much. If there are any other questions that come to mind as I continue moving forward, please feel free to drop them in the Q&A panel, or you can email those to me as well. We do have a few last couple reminders here. One of them being, we have our next webinar, which is open nationwide, on December 2nd. The time is 2 to 3:30 p.m. But of course, this depends on your time zone. And if you'd like more updates, please sign up for our listserv. You'll receive an amazing resource bulletin every month, as well as updates on our webinars and upcoming trainings. And then last but not least, we would love and appreciate your feedback about today's session. It really does help us be able to improve these webinars and cover the topics that you are most interested in. So please feel free to go ahead and find that link in the chat